everybody, and welcome to the Ryan White Part D Network Virtual Toolkit Series. My name is Allison Agwu. I am the Program Director of the Part D Johns Hopkins WICY Partnership for Excellence in HIV Care across Central Maryland. And for those of you who have not attended our Toolkit Series, the whole purpose of this Toolkit Series is to engage and amplify. So briefly about our program. So again, the Johns Hopkins WICY program is we represent 6 distinguished programs across the state of Central Maryland. And the goal is to provide quality, comprehensive, family-centered medical and social services to the WICY population of Pediatric Adolescent HIV/AIDS program. We have Women's Health Program led by Jean Keller and Anna Powell, Sinai, University of Maryland, the Emerge Clinic, as well as our psychiatric services. Again, our vision, more coordinated response to HIV care, our mission to build upon existing structures and systems, create a dedicated network of providers, and the goal of, again, this series today is to engage and amplify our local experts, which includes all of you. And then today, local is far-reaching as we have attendees from really across the US and across the world. Today, our program is called the implementation of a multidisciplinary breastfeeding program for women with HIV, a conversation about the who, the what, the why, and the how. It's, again, part of our Toolkit series. And I would be remiss if I did not pause to acknowledge today is World AIDS Day. And this is intentional and a special issue of our Toolkit series in honor of World AIDS Day, to honor those that have passed from AIDS and to highlight and to celebrate the advances in the care and the management of individuals living with HIV. Briefly, these are my disclosures. And I am joined today by a wonderful group of people that I work with on a daily basis that I'll ask to introduce myself. We're representing a bigger cohort of us that were actually part of presenting our experiences in the Peds article earlier this summer. As again, I'm Allison Agwu. I'm adult and Peds ID and the director of our Pediatric Adolescent HIV/AIDS program here at Hopkins. My colleague, Chris Golden, if you can mute yourself and introduce yourself, Chris, would be great.
Good afternoon. Christopher Golden, Associate Professor of Pediatrics. I'm a neonatologist and I'm medical director of the newborn nursery at Hopkins.
Marianne?
I'm Marianne Knott-Grasso. I'm a pediatric nurse practitioner and have been managing all of the moms that we see in the program once they're discharged from the hospital.
Do we have Allison here yet, Marinas?
I'm on. Can you hear me?
We sure can.
Okay. Somehow I end up joining as a participant. I'm Alison Livingston, and I work with the Johns Hopkins HIV Women's Health Program and work closely with the people on this panel. And I'm so glad everybody's here today.
Last but definitely not least is our fabulous mom who breastfed in our program. Go ahead, Fab Mom.
Wait, can I? Hi, Pablo's mom. I've been in the hospital for almost 3 years now, so they're off and on.
So excited to have you here with us, Fab Mom. And we oftentimes do this at the end, but really want to highlight our acknowledge the women and the families that have breastfed in our program, a multidisciplinary team, our funding from Ryan White and HRSA, Part A, C, and D, supported what we've done. And to let you know that our presentation today is adapted from what was presented at the Ryan White Clinical Conference in 2022. Again, World AIDS Day, really want to highlight that we are achieving equity to end HIV, and this is part of what we're doing here and talking about our program today. So briefly, our learning objectives today are to evaluate the evidence regarding breastfeeding transmission of HIV and the rationale for supporting a harm reduction approach toward breastfeeding for women living with HIV. And I'm saying women living with HIV because the data that were presented and in our program has been women, but to acknowledge that we can say breast, but also extend that to chest, where they're not all individuals who feed their children from their chest acknowledge them as breast. So individuals with HIV, but again, referring to women because of what our program has done so far. So secondly, identify key questions, the team infrastructure, collaboration, organizational and structural resources, including the funding that may be necessary when you're thinking about developing a breastfeeding policy and supportive program for women living with HIV. And lastly, the goal is to share and discuss. We really would love to hear your experiences as we share ours. I'd like to start with a case. So case number one, in the late 2000s, a pregnant nurse who's living with HIV, undetectable viral load, long-standing on antiretroviral treatment. She'd previously worked in sub-Saharan Africa and disclosed to her OB that she was interested in breastfeeding and the reasons for maternal and fetal health. The response at that time was literally a roundtable discussion between OB, Peds, ID, Neonatology, ethics, legal, the woman and her partner. And the outcome of that discussion was the woman tearfully rescinded her request when her partner turned to her and said, well, why would you want to do this? Case number two, 2018, a pregnant woman living with HIV, long-standing undetectable viral load on ART, disclosed to her OB that she was planning to breastfeed, and the reasons, maternal fetal health, but also the concerns of disclosure. The response we'll talk about and the outcome we'll talk about. So first, let's go to the benefits of breastfeeding. We have, again, thinking about breastfeeding, there's a big campaign about breastfeeding is best, recognize that breastfeeding is not best for everybody and to acknowledge that, but there are some things that have been associated with breastfeeding: improved immune system, improved eyes, decreased infections, higher IQs, and the like. We've seen increasing rates of breastfeeding. For women living with HIV, the reasons are the same: perfect nutrition, protecting their infant and child health, brain power, cognitive benefits. There are some additional specific reasons as well in terms of cultural norms and what's expected from individuals in terms of breastfeeding and the possibility of disclosure if they do not. Some stigma related to that, and sometimes safety in terms of maternal actual safety should the disclosure happen. So Fab Mom, in looking at these reasons for breastfeeding, did that resonate with you? Or those some of the reasons why you may have wanted to breastfeed your child?
Yes. When I was pregnant with my first child, I went to the hospital in Africa. So I was tested negative and I breastfed my child for 1 year, 3 months. So when I came here, luckily I came here in 2018. I was pregnant with my second child. So when I went to the hospital, I was tested positive. I was wondering, where would I get this virus from? But when I think, I couldn't get where I get the virus from. So I continued to live with it. So when I was pregnant, I went to Franklin Square, and Franklin Square sent me to John Howard King. Now I was there for like 6 months before I started talking about breastfeeding. When I came here, my mom asked me that if I was going to breastfeed my child. I said yes. And when I go to the hospital, they asked me if I want to breastfeed my child, and I said yes. They said, why? I said, because I don't believe in like giving formula to my child, because I never done it before. So I prefer breastfeeding than giving formula to my child. She said, no, some people breastfeed and some people give formula to the children. Then I said, I haven't done it before, so I just continue to do what I know. And I started thinking about it. When I was thinking about it too, I thinking about now for my child getting the virus too. So the two things were playing on my mind, if I want to breastfeed or I want to give formula to my child. So I just decided to breastfeed my child at the end. And when I gave birth, I started breastfeeding the child first. When a woman, when you give birth, like 1 week, you'll be having like a solar nipple, that your nipple will be sweating, or you'll be having like a little bit of blood coming from your nipple, right? So when I called my doctor, then I told her, and she said that, oh, if you feel comfortable, just continue to breastfeed the child. If you don't want, then you can come back to the hospital, which is Dr. Allison Agwu. She said, you can come back to the hospital, then we can give the child formula. Then when I thinking about it, I said, no, I will just continue to breastfeed. So when I go to the hospital with the child, to do his first test, he was negative, which was with nurse Marianne. So then I continued to breastfeed. Then my mom said, like, oh, if you have your nipple, if you have sort of nipple, you can't breastfeed. You have to take the child to the hospital for the people to get the child the formula. But they don't know that if I have the virus, because I haven't told them yet. So I couldn't tell her, say, oh no, I told the people that I'm going to breastfeed my child. She said, if you're breastfeeding your child, you can still give the child formula. I said, no, I don't want to do that. I decided to breastfeed my child, but I didn't explain the problem to her because I think that when I explained the problem to her, maybe they were going to hate me or they were going to like talk to me about something. So I decided not to tell them. So I just continued to breastfeed. And when the child was like 6 months, I went back to the hospital to test him. It was negative. So it made me encouraged to breastfeed my child. And I wanted to start when he was 6 months breastfeeding, but when I see him too, he is not eating anything. When I give him food, you know, he eating. When I try like different thing like cornmeal, like give him water, he would not take it. So I just continued to breastfeed until he was 1 year, 6 months. And no, he was 1 year.
Yeah.
He was 1 year. And when we went back to the hospital for the last, well, we haven't go by yet. They tested him was negative, so I decided to tell God thank you that he didn't get it. For me, Miriam told me that when he be like 1 year, when he be like 15 years or so, he can go back to the hospital for the panel test.
Yes.
So but I'm praying. I know that he will not get it. Yeah, because he didn't get it in the first place. So right now, where will he get it from? So yeah, that's made me, the first test made me happy. It made me feel good to breastfeed the child. Because also me, when my nipple was swallowed, where you're going to get it. Because when I was breastfeeding, he was getting like, when he holding my nipple, I think maybe the blood was going in your mouth or something. So I wasn't thinking about that and went to the hospital. They tested him was negative. So it encouraged me more to give him the breast milk instead of giving him formula.
I mean, you highlight so many of the reasons that, you know, it sounds like your mom didn't know, you wanted your health, the baby's health, so many things, and the communication and coordination between you, the nurses, the nurse practitioner, myself. So I think that that's exactly what this is about today. So thank you for sharing that. I think briefly want to talk about the risk of breastfeeding. So I think that that's really what gives people pause. And I hear you talking about that. So I think first, just even talking about the risk of perinatal transmission, I'm assuming most people on the call understand that the reality is that without any antiretroviral treatment, we know that transmission does occur. We've moved with lots of research over the past 30 to 40 years, antiretrovirals in labor decreasing down to 9 to 13%. Our current rates with optimal antiretroviral therapy, our transmission from mom to babies is less than 1%. And when we do have babies that acquire infection, it's really when moms do not know their diagnosis until after birth or their diagnosis is unknown at all. And our rates of diagnosis have declined significantly. When we look at transmission risk, the cumulative risk of transmission of HIV via milk when moms have chronic HIV infection, no ART, almost 14% no ART. 25 to 30% among moms who acquire HIV during late pregnancy. And this is not what we're talking about. We're talking about women, known diagnosis where we're initiating antiretroviral therapy. When we think about factors associated with increased risk of HIV transmission, high maternal plasma load, human milk viral load, which we don't measure regularly, right? So that's something that we would do in a lab setting. Having low maternal CD4, advanced immunosuppression, the longer you're breastfeeding, the possibility of mixed feeding. We have mom allude to the fact of having mastitis or nipple abnormalities, if the baby has oral lesions, and then if there's mixed feeding. But the WHO has talked about this in terms of recommendations for breastfeeding. And in low middle income countries, standard of care is for persons living with HIV is to breastfeed. And the idea is that it promotes survival and well-being of both positive babies and exposed babies. When we look at the risk of transmission, I'm going to go through these somewhat quickly. When we looked at the risk of transmission in several studies, the highlights here, postnatal transmission risk up to 6 months of age, about 1%. Again, higher risk for moms who start ART in the later stages of pregnancy. We have had studies in Botswana and Tanzania showing low to no rates of no transmissions as much as 11 months post-delivery. This is the Mama Bena study out of Botswana, where women were randomized to triple nuke versus PI-based ART, and they were given that through weaning at 6 months of age. And some babies all received single dose nevirapine and zidovudine. And in this rates, we had higher rates of viral suppression to less than 400 for the moms, less to 50 for moms, so even lower. And in terms of transmission, very low rates of transmission and breastfeeding transmission of 0.3%. So the bottom line is extremely low risk of HIV transmission when breastfeeding is with sustained viral suppression. I think it's, while we're talking about, these optimal rates, we understand that there are many factors that go into whether a mom can stay suppressed or get suppressed. There's maternal factors, there's economic factors, transportation costs, can they get to clinic, unemployment, social determinants, and then postpartum retention in HIV care. As we know, loss from care is exceedingly high. And of course, there's related stigma that our FAB mom talked about, and the cultural norms and what's expected in terms of your care. So many of those things we talk about also, however, there's this idea of cell-associated virus and what exactly and where exactly is virus. And that factors into whether or not we're thinking just about maternal ART or whether the infant gets ART as well, which is part of the reason why in our program you see that we also do infant ART as well. So what about breastfeeding in high-income countries? And this just highlights what is considered low versus high-income or high-resource countries, with the areas in red showing areas that are lower income, and then blue and light blue higher income locales. And this is breastfeeding in those locales, showing that we have highest rates of breastfeeding in low-middle income countries, but not shabby in the ways of 30 to 40% of breastfeeding. And this is not just women with HIV, but this is all comers. There are some unanswered questions about breastfeeding in high-income settings, and this was highlighted well in the Lancet article by Waite et al. So, first, what is known about what is significance of cell-associated virus? What is known might be associated with transmissions in women with or without suppressed viral load, but it's unknown. I think it's a research priority. What is the genuine rate of transmission? Is it truly zero? Can U equals U be extended to breastfeeding? And I think what is known, very low rates are reported, but you have had cases of transmission in undetectable viral loads. And so though very low, what are the factors that determine that? What are the PK of neuroantiretrovirals in mother-infant pairs, particularly as we move to injectables and other things? What does that look like? How do you monitor for toxicities? Are any regimens better suited for breastfeeding? And what is the optimal frequency of biologic measuring? What steps should be taking? What is the significance of mastitis? So lots of questions that some, again, raised by our FAB mom as she was talking about her experiences, and opportunities for us to do research to understand more. We do know, though, there are health risks of not breastfeeding for U.S. women living with HIV and their infants, and to think about not just the obstetric complications, the metabolic syndrome related to that, and for long-term complications for infants and not breastfeeding, as we talked about the benefits of breastfeeding. Again, having breastfeeding as an option on the table. So what are the recommendations? And this is a graphic from the CDC, and certainly visit your provider regularly. The risk of transmission is low in the setting of optimal antiretroviral therapy and not breastfeeding. And currently the recommendation is to not breastfeed or pre-chew or pre-masticate your food. And that's standard. However, guideline recommendations across the globe have evolved. I know we had some interest in this webinar from our UK partners, where formula is preferred, but they're ahead of us in terms of supporting breastfeeding among those who choose to breastfeed. IS does not, or International AIDS Society does not address, and the DHHS of the U.S. Department of Health and Human Services recommends breastfeeding. Breastfeeding is not recommended, I apologize. but since 2018 has talked about a supportive or risk reduction or harm reduction approach. WHO's who talked about exclusive breastfeeding. And again, more guidelines are starting to at least acknowledge or recognize this is an issue. Should say the CDC did update their recommendation in March 2022 and referred to the perinatal guidelines with, again, more of a stance of should moms choose to breastfeed, patient-centered evidence-based counseling on infant feeding options and allowing for shared decision making. And if the mothers choose to breastfeed, providers should emphasize the importance of adherence to ART and sustain viral suppression in terms of decreasing transmission. So now we turn to our JH-U multidisciplinary team. I think sparked by the case number 2 that we talked about earlier, our team included all of the individuals with centered on the mom in this case, and included ID and HIV providers in both adults and pediatrics, OBGYN, labor and delivery to make sure that there is inpatient, outpatient communication, our lactation consultants, the ethicists, our legal team, pediatrics who will be following, and neonatology. And all sort of got together in the room, at that time a physical room, and have converted to a virtual room, highlighting the fact that everybody coming with their concerns and putting together a protocol to be able to do this. And in the aspects of those that were then antenatal consultations that were determined and have systematically been done for individuals choosing to breastfeed. I'm going to pause for a second and turn to Dr. Golden. Chris, you were really our local champion here. I'm getting all the parties together. I wonder if you can talk a little bit about the process, how easy it was, how difficult it was, why you wanted to take this on. Maybe come off mute and tell us a little bit about that.
So thanks, Allison. The idea really came about in the setting of having mothers who were inquiring. And we have a population in Baltimore that is truly international. And we recognize that are women that come from countries where HIV status does not preclude them from breastfeeding. And again, it's encouraged based on many of the local factors, if you want to use the phrase social determinants of health in sub-Saharan countries, that can be applied as well. That led them to breastfeed. They then came to the United States and we put up, in many cases, a stop sign and asked them not to breastfeed. So when women came over with the idea, we floated the idea around. Again, hard to change based on the concerns we have. And again, knowing we've come so far in reducing the acquisition of HIV in the perinatal period to then introduce the possibility of a baby acquiring HIV by something that we could avoid by using simply formula. However, many of the social factors combined with mothers who want to do this and want the opportunity to bond and have a natural experience. In our experience here at Hopkins, we've had many mothers who said, I just didn't bond with the baby that I gave formula. I bonded more closely when I breastfed a baby when I was HIV negative. And now that I'm HIV positive, I want to have that same experience. As a result, we decided to get everyone in the room and have an open discussion about things. I think we sort of tangentially had the ethics people involved, but everyone else that you have here described in this slide was involved in the discussion. And what was really difficult, I think, was from the labor and delivery and lactation side and the postpartum side, because many of these nurses, again, had been ensconced in this belief that HIV positive mothers should never breastfeed. Now, again, the population that we selected are women who abide by the guidelines that we set out, and I think you're going to talk about later, are these women who are controlled in terms of their viral load, suppressed, and have agreed to continue their suppression, their suppressive therapy, and are able to provide that for the baby. We do this with this counseling idea, again, of getting everybody in the room, the obstetricians, the neonatologists at the time, and having a discussion and making a plan for follow-up. Once we got all of the players on this slide in the room, we then decided to move forward with it, but again, cautiously and carefully looking at mothers who were at risk for relapse or sort of higher viral loads because of other factors, such as medication availability, ability to comply with the regimen. And we did a very good job and continue to do a good job of screening moms for high-risk behaviors that might not allow them to be successful with this program. So this, just to make clear, is not a program where we let any woman who's HIV positive and we endorse and support breastfeeding. This is a very controlled and very guided process where women are allowed into our system and allowed to work with us, and we give them the ability to work with us to achieve this goal.
Yeah. I think, one of the things I think that was really important was we had it was an ethics hour. It was attended by very well. And I think what was really strong for me, a strong memory for me, was a woman that I had taken care of for years and had never even thought to ask her about her experiences about breastfeeding, and being in a room with her and just saying, oh, we're the guidelines are moving towards this. She's had 3 kids, and said, what did you feel about not breastfeeding with your child? And watching just her face collapse. And, it for me was like, wow, she participated in the ethics conversation, but had not realized the impact we'd had on those women. So thanks for really, there were lots of emails and pushing us to really talk about this and to get to a different place. And we've had our arm wrestles about this as well. I think it's important to say that not everybody came with let's do, because you were right. We spent so many years saying you cannot do this, and even trying to get the inpatient team on the same page was challenging. But I think we got there.
And just a quick point, just again to say that we continue, and this is not something that's a one-size-fits-all program.
Correct.
Each of the women has an individual counseling session with us.
Yeah, we'll talk about that in next slides.
Yeah. Okay. Great. Go ahead.
Don't steal Allison's thunder.
I won't steal your thunder. Go ahead.
Yeah. So Allison, maybe you can talk a little bit about the OB approach. And again, the asterisks were all the consultations that we shared that happened in advance. Go ahead, Allison.
Thanks so much. So essentially, what we do is when somebody comes to us for prenatal care, we do a very thorough nurse history. And with a patient who's living with HIV, we dig a little deeper. So we take a look at the eligibility criteria, parental factors, comorbidities. One of the things that is asked on kind of a standardized nurse history is, what are you going to do, formula or breastfeed or both? That's the standard. And so typically what I will ask is, how are you planning on feeding your baby? And this kind of evolved because then people could say, oh, I was going to breastfeed, but not tell anybody. Or I don't think I'm allowed to breastfeed because I have HIV. And just like Dr. Agwu was talking about, you would see faces change and the whole feeling of shame and stigma around, here I am having a baby and I can't do this, I'm not allowed. And then for a lot of women from Africa who were very afraid that they would be outed, essentially. If they weren't breastfeeding, families would be like, what's wrong? Why are you doing this? And fear of not bonding. So we take a look at the reasons for breastfeeding, the challenges, does it look like, milk production? We get, lactation consults to see, well, how would the milk production be affected in this person? Their antiretrovirals, making sure their labs are monitored, talk to them, just as we do anyway with pregnancy, about their adherence, take a look at their social determinants of health, all those things that would affect their ability to breastfeed. And just like I talked about, disclosure. And so when a patient expresses an interest, we make sure that the whole team is aware, and we arrange a consultation with the Peds ID team, and for them to really sit down. The most important thing is that, it's supportive care for their decision and risk reduction. And that we really work with the patient so that they can make an informed decision, so they can understand the risks. And so that's essentially the process from our perspective. And then continuing, obviously, to support them through the 4th trimester. And we try and continue to work with Marianne and Allison with their team.
I think I love what you say here, because we certainly have had these virtual consultations that have been really helpful, and where, Chris, you made the point that it's not so much letting people, it's helping them understand what their risks are. We've had a few scenarios where someone's viral load is detectable and low detectable, but still detectable. And we've said, listen, we really, our goal, we've had success with getting you to undetectable. What are the factors that's impacting your viral load now? And work with them. Oh, pharmacy hasn't delivered. And it actually has allowed us to get people to the point where they can reach the criteria. Because you're right, we really are looking for optimal cases, right? People who their viral load is low and they can successfully do this.
And the other thing I'll quickly say is that it's important to recognize that this is not a scenario where a woman has only one choice, that she must breastfeed her baby.
Oh, absolutely.
We have had women who come into this process and they've said, I heard the information, I've listened to your presentation, you've given me great information, and I want to formula feed my baby. And to that point, we say, we support you in formula feeding your baby. This is not in any way dictatorial or paternalistic. It is a way of giving them information to help them make an informed decision.
Right, absolutely. Allison, what is your sense of what proportion of women that are choosing to breastfeed when you present that as even an option?
So, it has changed, it has increased. So what I've noticed is I think there's more talking in the community, people aware of other guidelines, the World Health, et cetera. And I would say, like, if I look back over the last, say, 4 years or so as kind of an average, I would say, probably about 10%, but depending on the year, the more we've headed to 2022, the number of actually, I think, going ahead and breastfeeding has been closer to like 15 to 20%, but the interest has been higher. We've had a lot more conversations with people, and the conversations that we have at the nurse history then will continue. I let them know, I said, every time you come, we're gonna just check in where you're at with this, because people change their minds. That's the other thing, is they change their minds, and we need to be prepared. And so what I've found is that a lot of people then after a while, they never actually even don't want the consult, because they've decided just based on the information that they have that they actually don't want to breastfeed. But we continue to talk about it. So I think the interest is greater, and then the actual completion is greater as well.
Yeah. I think Fab Mom, were you surprised that you were asked about breastfeeding?
Oh, sorry, say that again.
Were you surprised that you were even asked about breastfeeding?
Yes, I was.
Yeah, you were expecting them to say it was a categorical no. Yeah, so that's helpful. So one of the things we'd love for you to talk about is in the interpartum what happens, because you write up this week, we have a meeting, you write up, you send a fabulous sort of summary to the team to say, here's what the factors are, and then we have a consultation, and then you pass on to the inpatient team. And sometimes we worry about that handoff. So maybe you could talk a little bit about what happens intrapartum from an OB perspective.
Yeah, so what we really trying to is make sure, again, that the team is aware. We've done a lot of education with nursing and labor and delivery. Every time somebody comes through, there's a training, fellow residents, that they're present for one of the discussions that we at least have in clinic, so that they understand there's a lot more familiarity now just in labor and delivery and postpartum, because that was something, as you mentioned, there was kind of this wall, like, this is not okay, you can't do this. The viral load going into delivery, we obviously want an undetectable viral load. At Hopkins, we hang AZT during delivery. Not everybody does, but that is something that we follow. Lactation is incredibly helpful in this process, because they're going to be assessing milk production. What if the mom's milk doesn't come in right away? We have to have that discussion about what happens if your milk doesn't come in right away and the baby needs sustenance, and what are we going to do? Because once the thought is right now that you cannot mix the formula and breast milk. And so once that baby is started on formula, we can't go backwards. So there's a lot of, discussion about donor milk, and I would say that, Marianne is instrumental in a lot of those discussions. And also, we want to make sure that no matter what, there's not unintentional disclosure for the mom status. And, it's difficult because some of our moms have not disclosed the status to the father of the baby. And, the baby's going to continue to have medication anyway, but longer for the mom breastfeeding for that duration. So.
Okay, great. I'm going to switch to turn to you, Chris, from the neonatology perspective, and talk a bit about the antenatal assessment and I did not highlight before. I know you need to leave a little bit before 1 o'clock, so you'll be first if there are questions that come for you. But go ahead and talk about the neonatology.
So during our session, we talked with the mothers about what is expected with regards to their adherence to medication for themselves as well as the baby. And we highlighted, I think Allison Livingston did a nice job of describing some of the things that we talk about. Who knows within the family that you're HIV positive? How will you make the baby's medication administration such a non-issue? Will there be people that will be inquisitive, nosy, if you will, and trying to find out why your baby is taking the medicine and what medicine that they're taking? We strongly discourage and actually do not support in babies who were born prematurely. Again, from the PROMISE study, there was data that demonstrated there were some preterm babies in that population. However, the data was presented in a manner such that we're not sure how the outcomes of those babies were. And because we worry about the immaturity of the neonatal gut, as well as their immune response, we say 37 and 0.7 weeks is when we would start to entertain this discussion. Other medical issues that arise during the neonatal period are contraindication, things such as congenital heart disease, acute neonatal encephalopathy in the setting of hypoxia. Ischemia is another great example. And with regards to feeding issues, we also talk about using donor breast milk, which we do have a supply of at Hopkins, and that is a time-limited exposure, again, so that the mothers and the babies get that opportunity to provide food for the baby during their hospitalization until their milk comes in. So those are the things that we discuss. We also do all of the routine care in terms of starting the antiretroviral medications. The other thing that we have at the time of decision, with the mother decides that day or later on during the pregnancy but prior to delivery, is having her sign a waiver, essentially noting that there still are risks. It's not a zero risk of the woman transmitting through breastfeeding, but that she agrees to go forward with that. We have not had problems with women agreeing to sign this waiver. Again, it essentially delineates all of the things that we noted earlier with regards to adherence to maternal medications, adherence to neonatal medications, close follow-up with Dr. Agwu's group and Ms. Knott-Grasso's group in terms of follow-up as an outpatient, noting if there's any evidence of mastitis and those things. And once we have them sign that waiver, we then scan that and put that into the chart. And we've not had difficulties with women refusing to sign that waiver. Thank you for bringing that up.
And maybe a little bit of the interpartum, if you want to quick, I think you covered a lot of this in terms of.
Yeah. So again, we do start the antiretroviral therapy, the triple lamivudine, zidovudine, and nevirapine at the time of initiation of breastfeeding. We have routine HIV labs that we monitor DNA and RNA tests, as well as CBC. We, again, support them with donor breast milk. If we have a baby that needs a short NICU stay, we will do IV fluids in the interim. Again, we want to make sure that they are plugged in, that the baby has medications. We've had our social workers involved with many of these women, to the point of even going down and getting the prescription for them so that they walk out of the hospital with all 3 prescriptions for the baby. And then we, again, cannot absolutely guarantee, but whenever we have discussions with women in the intrapartum period, we ask a parent, another family member, or someone who may not know to leave the room so we can have the discussion. And again, we warn mothers that there is the unintentional possibility that there will be a disclosure. The CARES Act has taught us very importantly that a dad may have access to the chart. And that is something that we warn mothers about as well if there is an issue that arises. We then also make sure that lactation is involved. A lactation consultant also is involved often in that initial conversation we have with the mother prior to delivery. And if the baby needs other supports, we involve those team members as well. And we do have the infectious disease service come by and see the baby, and they actually will call Allison to make sure that the things are on point and appropriate.
I think briefly we can talk about the Peds ID, perspective. And again, being involved antenatally is really critical. We meet all these moms and are part of the plan, and then we write a note. So communication is so important. So again, some of the same things that were mentioned from others, but also we are looking at what the plan is, for follow-up. What is disclosure concerns? We work through what is your plan of how you're going to be able to give this medication, because your child will be on a medication. And then our recommendations are, exclusive breastfeeding. And there are times where we may say as a team, we don't think this is the right scenario to pursue this because they're a risk. And then making sure we have a plan to comply with monitoring, visits, et cetera, and that there is understanding of anticipatory guidance. I think we heard Fab Mom talking about, well, if there is a mastitis, who do I call? And we have the bat phones in play so people know who to reach out to for support. In the postpartum period, while in the hospital, there's a Peds ID consultation comes in case there are any changes that have happened since the antenatal. There's, maternal viral load in labs at delivery, we reassess that. And again, the comorbidities, et cetera. There is AZT, 3TC, nevirapine, and treatment doses are done for the first 6 weeks, and then nevirapine twice daily until a month post breastfeeding. And again, preventing unintentional disclosure, monitoring, changing doses. But in this case, I'd love to turn to Marianne Knott-Grasso, who has seen all of our mom infant dyads, to talk a little bit about the postpartum period, the weaning, et cetera, and how that has been. Marianne?
Okay, thank you, Allison. As you've already heard, the medication is initiated in the hospital. I routinely see the babies within the first 3 to 5 days following birth to assess a weight, see how it's going with the medications. We are blessed to have the support of the Ryan White grants, in that we have been able to make available to the moms at no cost some devices to assist with administering the medications, such as nipples that the syringe will attach to so that the mom can administer as the baby's sucking rather than directly in the mouth, to make sure the baby's getting the entire dosage of medications. I've had a baby that was born in an outside hospital that it was recommended the mom mix the 3 medications with a small amount of formula, which is not a recommendation at all. It's to administer from the syringe to make sure that the baby gets the entire dosage. We've also tried to address the problem of moms who want to remove the name of the medications from the bottles by using a color-coded system. We standardize the color we use for each medication, and I also include that on the direction line for the medication so that everybody's kind of on the same sheet of music. I give the mom extra tape to take home and put on the bottle so that the syringe color matches what's on the bottle, which also matches a small piece of tape on the after visit summary that lists all the medications. In order to prevent unintentional disclosure, that's an across the board challenge to come up with reasons to dismiss certain people from the exam room when we're talking with moms and babies. And our plan is to follow up each of the mom baby dyads monthly and coordinate with the specialty care providers. We then also try and make a plan for weaning when the mom decides that she's planning to discontinue breastfeeding. The medication, the nevirapine, we continue for 4 to 6 weeks following the termination of the chest breastfeeding. Can I advance the slides? Thank you. One of the issues we had with lab monitoring was trying to coordinate the mom getting her viral load done. Given HIPAA, moms are not primarily my patient, but I think in this case, we can say that mom is under my care with respect to the breastfeeding. And so I have now gone in and I order the mom's viral load testing so that she can get her labs along with the baby. As Dr. Golden said, we do the 2 lab draws in the nursery, testing for HIV, DNA, and RNA. This is repeated at 2 weeks, 4 weeks, and 4 months of age. We then, about every 3 months, I test the infant, and we follow up about a month after breastfeeding and then 4 months after cessation of breastfeeding. In all of our exposed babies, we also recommend a HIV antibody test at 18 to 24 months to test for clearance of maternal antibody. Usually this is cleared by the time the baby turns 2 years. In breastfeeding, it can be a bit more prolonged depending on how long the mom nurses. And the reason for documenting this is so if the child at some point in their life becomes test positive, we can assure the mom that she did not transmit HIV to her infant.
Thanks, Marianne.
Yep.
I think as you alluded to, it's been so critical to have care coordination. So it's notes, it's conversations across the teams, but also with the family. You know, Fab Mom has your text, she texts, my charts, you know, if a message is sent, it's sent around to everyone. If she's seen the adult side, the feedback is to the ped side. So it's not siloed care. It's got to be coordinated. Assistance with insurance or financial assistance with Ryan-wide funding, emergency financial assistance, infant supplies, trying to make things as easy as possible to then be able to hear, ride share, parking vouchers, the like. So I guess we can turn to and say what happened in case number 2. So the response was that multidisciplinary team sitting together, but now with mom at the table and less of a, this is what you need to do, but talking through about things, including women who had not breastfed before and saying, well, what did you wish? And the outcome is she delivered a healthy term infant and breastfed for 6 months, and that infant is negative and remains negative. So I think certainly we have reported our experience as of this report, which was in Peds earlier this year. We had 9 women who had 10 infants. We since have had another, I think it's 4 women who have reached the end of the babies have finished breastfeeding. We've had, I think, 1 or 2 who have recently started to breastfeed. 1 started, 1 finished. And so of all those infants, none are positive. And so this is through, again, very protocolized approach that we've done here. This was published along with an editorial for, and, you know, cautioning against. There are both, and I would encourage you to look at both the article as well as the editorials that have come along. We're not sitting here saying we're the only ones doing this. Since our article and some prior, there have been reports in Germany, Switzerland, the UK, and the British HIV Association, certainly here in Washington, D.C. as well, others reporting their experience in Canada of women living with HIV who've breastfed with different versions of their protocols. I think, you know, there have been many requests for our specific protocol, and we actually have under review a protocol at Lancet HIV, but we are happy to share that again, recognizing that it's iterative and you have to see how it fits into your institution. I think really important to talk about is the idea of criminalization, particularly in the environment that we live in the US currently. 35 states have laws that criminalize HIV exposure, and some of them are very, very general, but some can be specific, and many have laws that fall into more than one of those categories where criminalization is potentially an issue. I think in a nice article in the Journal of Medical Ethics talked about specifically maternal transmission of HIV infection, and to be judged as reckless, as a quote from the article, it would have to be judged objectively unreasonable for the mother to breastfeed given the risk of transmission. So a viral load of 2 billion with no antiretroviral therapy wanting to breastfeed. And this is not what we're talking about. The AP has addressed this in the past, in 2013, by Lynn Matheson, that a mom's desire to breastfeed does not constitute grounds for an automatic referral to Child Protective Services, and that's a stance that we take as well. The AP statement will be revised early next year, and looking forward to that, because we have heard, unfortunately, of situations where this is criminalized. So to that, I think in summary, there's evidence to support a harm reduction approach toward breastfeeding for women with HIV. It really is important to think about the team that you need, the who, the what, the where, all together as you develop that program. Before we go to the question and answer, I'd like to turn to our fab mom to ask her, what did it mean to you to breastfeed your son and to have this whole team around you supporting you in your decision to do so?
Well, I just like made the decision to breastfeed my child because I feel like breastfeeding the child would be like attached to me or connect to me more than the formula. That's why our people believe, like, if you breastfeed your child can be attached to you in any ways. Like giving the child formula, it can make some children brave to do like a lot of things. That's why our people believe. So that's what made me like encourage me to breastfeed my child.
And do you feel he's attached to you?
Yes, he is. He is really attached to me. Sometimes I run away from him, so. But when I'm in the house, I don't leave my room to go any other places. Yeah.
Awesome. Well, with that, I'll turn. Thank you all for sharing your experiences, and particularly you, Fab Mom, for talking about it and for being really an awesome just a patient and mom in our program. Would love to turn to some question and answer. There are a few questions in the chat that I can take. And let's see. Yes, and Elizabeth Lebo is talking about, there have been now 4 new perinatal transmissions that have been reported in Maryland since July. And some of those, even among an older the child where mom was not the diagnosis and mom was missed. And I think one of the things and reasons why we really are looking to try to support individuals, and no matter how they choose to breastfeed, is that we know that if you have the constraint of disclosure or stigma and do not feel supported in your decision to breastfeed, you may do it anyway. And we want to make sure that you're supported to be able to breastfeed as safely or chest feed as safely as you can. So thanks for bringing that up. I see a hand up by Carmelita Abel. Go ahead, Carmelita.
Yes, I just want to say thank you for bringing this information to us. I've been looking forward to this discussion for a while. I just wanted to know, a person who be interested in you guys' services, how could they go about reaching you?
Yeah, certainly. So I have my information up here. You can reach out to me. The Well Project has a listserv of all providers across. If you're not local and you're interested in breast or chest feeding, they have a list of providers that are doing it in your setting. So would refer you to the Well Project, but absolutely feel free to reach out to myself or Marinus Terraforte, and we can link you if you're local as well to our OB folks and the like.
Okay, thank you. Can you make that bigger, please?
which I personally can't because I am challenged, but we'll try to do that. Let's see. Oh, I can. Let's see. Oh, yeah. Don't get me to trying to do that. I definitely can put it in the chat. How about that?
Okay, thank you.
Showing my my limitations. Mothers, let's see, I'm looking at the questions here, and please feel free to raise your hand if you haven't. Chris Golden had to leave, so if there are any questions for him, you can send those up. I see Krista Martell. Thank you. In terms of our cohesive program, it's been a work in progress. I mean, we've been doing this for a little bit over 4 years now. I think in terms of resistance, I think it was important to have legal at the table to make sure that we explained to them all the things that we're talking about today. I wouldn't say it was resistance, but more caution, and to work on something that works for everybody. Because there is a concern. Well, what if the child acquires HIV and then comes back and does, sues us in whatever years, except there's all those discussions have to be had. And I, always say, just because the discussion is hard, the question is hard, doesn't mean that it's not worth discussing and worth doing it. And so I think resistance is not the word, it's more of concern and, hey, you've beaten to us for so many years to do it a different way. Why now? And why do we need to do this? And I think that's more what it's been. Second question, do you have advice for those who may try to assemble a multidisciplinary team who are not part of the same institution? I'd love to hear the other panelists on this as well. I think, from my perspective, I think it's really just about knowing who your friends are and who to reach out to and coordinating, reaching out and talking. I think will be really important, and then documenting and sharing and making sure it's a little easier now that we have shared electronic health records and things like that allow things to be seamless. But I think it's bringing a team together and identifying and making sure that it's clear who those team members are and having open communication. I don't know if Allison or Marianne or anybody want to comment on that one.
Yeah. No.
Oh, Felicia, I think you need to mute.
No. It's all right.
Yeah, I actually wanted to say that our social work team and community health workers are essential for all the communication, and is key because we really have to have a team approach for this to be effective. And often I find that, a mom will tell me one thing, tell a community health worker another thing, tell the physician something else. And so if we kind of come together and get the big picture, I think things are just more effective.
Yeah. So I just thank you for that. Would agree. And I think I answered in the chat in terms of social work support, huge with our Ryan White funds. We do have social work case management, as well as, nurse and medical case manager and outreach specialist. And those are key, right? So it's prescribing but it's all the other things that happen and that are identified and dealing with those social determinants are critical. So absolutely important. Looking at, just trying to make sure I have everything. So there's some comments about the feeding and if mom's milk doesn't come in, and Dr. Golden talked about donor milk. I will say in several of the reports that have come out, and even in the WHO, there's discussion about mixed feeding. Sorry about that. Mixed feeding, and I think Judy's comment is correct. A lot of the data is pre-ART or early ART era, and many of the reports that have come out that I put on that slide have included some moms who have mixed fed. So, again, where we're sort of in the strictest of, if you had to do this perfectly, what would you do? There are scenarios where we try to bridge, but, recognizing that may be challenging. And I think those are some of the things that when we looked at the questions that need to be answered, I think really looking at this mixed feeding approach in the setting would be important to do. Okay. And then Judy, your comment about the regimens. So to date, we have done the high risk prophylaxis for 6 weeks, and then done nevirapine. We absolutely hear that others do it differently, where some do zidovudine alone. We have just, again, starting out the gate with something that really was new and new for us, definitely not new for a lot of other places, have gone with the high risk prophylaxis and with the nevirapine is D and 3TC, but certainly do hear that others do it differently. The British guidelines don't do anything similar to what we do, right? And have had success. So I think it is about, you know, relooking and examining what is ideal. So good comments.
Allison, I'd like to get back to the donor milk issue. We did have one mother. Well, there have been several cases that we've used donor milk. There was one mother who didn't have sufficient milk supply, who was able to purchase that throughout the period of breastfeeding for her child. That's cost prohibitive for most families in that its insurance doesn't cover it at all, except for during the hospitalization. I also had one of our families delivered at a different hospital that was not supportive of using the mom's milk. That infant was a slow feeder and received donor milk throughout their time in the hospital. And then once they were discharged, I was able to initiate the treatment level 3 ARV cocktail that we use. And the mom was then able to transition to breastfeeding exclusively.
All right, I'm seeing the time and recognizing that we've reached the end. Want to pause and say thank you everybody for your participation, your questions. We will circle back and try to answer the questions in the chat or send you an email. The recording will come to you as well if you registered. And I think this is a beginning, not the end of a conversation at all. And really would love to hear from you, love to hear what you have to say, what you're doing, and happy to be a resource to what you're doing. With that, I think we will stop and say thank you for your attention and your time. And hopefully we'll see you next month at our next toolkit. Thank you, everybody, and especially Fab Mom for your participation. Have a great day.
Thank you too. Thank you,
everybody.
Thank you.